My name is Srolovitz, pronouns are she, her, and I currently work at Penn Medicine Hospice, which is a part of the University of Pennsylvania Health System in Philadelphia, Pennsylvania. I became board certified in 2015, the beginning of the year. So I've been board certified, 7 years or so now. And I've spent most of my career working as a music therapist, specifically in hospice care. So also had the experience working in private practice, mostly with geriatric patients. And I briefly worked with children and young adults at a cerebral palsy school, mostly with focus on didactic music therapy support. Prior to this, I received my bachelor's degree in both jazz performance and music therapy. It was a joint degree between Westchester University and Immaculata University. I completed my first master's in music with a specialization in neurologic music therapy through Colorado State University. And also working on another master's right now, which is specifically in hospice and palliative care with a focus in psychosocial spiritual care through the University of Maryland. And that's fully online, so easy to do it while working, which is great. In general, I always start with a verbal check-in, just assessing the patients and their loved ones' current needs, how they've been functioning physically, emotionally, coping with their serious illness, their anticipatory grief, whatever might be going on in the moment for them. From there, I'm able to offer various experiences which may assist with meeting the clinical needs that they stated, such as engaging in receptive music listening, utilization of patient-preferred music, which for the most part is all live music. I rarely use recorded music unless indicated for a certain reason. So depending on the patient's functional abilities and interests, we might also engage in more active interpersonal music making through engagement in improvisation experiences or songwriting for further creative emotional expression. First, when a patient is hesitant to receive music therapy initially, maybe the referral is made or maybe the team is discussing with the patient the possible indication or benefit from music therapy, but they're not quite sure. I often try to offer to do a joint visit with another team member. So working in hospice, it's interdisciplinary care. So oftentimes I'll do a joint visit with the nurse or the social worker. That way we can do more of a soft handoff in order to build rapport and trust with a team member who the patient is already familiar with and who is already comfortable and trusts. Also, during the initial assessments, there are times when I might not bring instruments or any music in with me at all. This is in order to foster rapport building, just getting to know the patient and for them to get to know me through just a verbal modality, which is often, of course, more familiar, more comfortable for folks rather than jumping into music experiences which might not be familiar and therefore might cause anxiety or fear. When introducing live music interventions with patients who may continue to feel hesitant with engaging in music therapy, I often encourage receptive engagement initially while integrating their non-musical needs into the music experience. So like for someone who's feeling anxious or agitated, I might offer a receptive experience, which allows the patient to not feel like they have to do anything. You know, the doctor comes in, they're asking all these questions, or the nurse, the social worker. During music therapy, if this is a time where they can engage receptively without having to do anything, that can be a great way to foster, again, that rapport building, that trust, and to continue our work together. Elements of music such as melody, rhythm, harmony have been shown to bypass lesioned areas of the brain due to how music is processed in the brain, so that for a patient who has suffered a stroke or other specific neurologic injury and who can no longer speak, for instance, they might still be able to sing. As we're working through singing, let's say specific phrases, so saying, I need to go to the bathroom. If it's hard to say that, but we can vocalize it or sing it, we're able to work on that, singing it, maybe using some other music support in the background to support that, the melody, the rhythm, the harmony. After we're practicing that, we're able to remove the music stimulus and the background support, and we see that patients are able to generalize their singing to remove the singing, remove the melody, and begin to speak that phrase instead. You think about music itself, it's such a temporal experience. So it's existing within one moment of time, but that temporal aspect is really key. When people engage in music experiences together, there is evidence Similar to the mirror neuron theory, which is definitely judged differently by different people, but that theory, we understand the synchronization of neuron responses, which occur among those engaging together. And so engaging in music together, we can really see that. Really, for all of us creative arts therapists, we are continuing ongoingly to have to advocate for what we do, to assist the public and stakeholders in understanding that our work for music therapists is not entertainment. For art therapists, it's not just arts and crafts time. The amount of education and clinical training that we have to go to become licensed and board certified music and art therapists, along with the continued education requirements, which I think are very similar to those of other medical professionals, really points to the high level quality of care that we provide to patients and often their loved ones, depending on the clinical setting. So we're able to meet people where we are, again, through multiple domains of humanity, so social, physical, spiritual, not only the physical or medical domains of care like nurses or doctors might engage with. When we see that involvement of music therapy and how it can assist with decreasing polypharmacy in patients with serious illness, for instance, that shows stakeholders that what we're doing in meeting patients' needs is a way which is non-invasive, it's much more cost-effective, and really is without many negative side effects. For the most part, understanding what we do is of utmost importance as we continue to advocate for our disciplines.